So today we're going to talk about the codes that you can report. There are few codes that you can report that help represent the work that you're doing in the medical home. So we have to be a little bit creative and look at codes and how we can best use them. Number one, there are a few codes that we can use. And number two, if there are codes that are unique to some of the services you're performing, they're often not reimbursed by payers. So again, we have to get a little bit creative when we talk about coding for medical home. This is just a disclaimer. So we're going to talk about the evaluation and management codes, prolonged services, after hours, care plan oversight, and then the two new code sets, complex chronic care coordination, transitional care management, and then developmental and behavioral screening. So the first set of codes that we want to look at are your preventive medicine codes. And of course, this is an integral part of the medical home and providing preventive services. These codes are basically just separated by age and whether the patient is new or established. So these are your established patient codes, and just as a reminder, an established patient is one who has not been seen in your practice. An established patient has been seen in your practice within the last 3 years. So in order for them to be a new patient, they cannot have been seen within the last 3 years by you or a partner or anybody that's covering for you in your practice. The next slide talks about some typical reimbursements that we see for other services that are provided in with preventive care or EPSDT. And a lot of these services are separately reportable, and they're also separately reimbursed. We know that they're separately reimbursed by our TennCare MCOs, and with the implementation of the Affordable Care Act, we're going to see a lot of these services required to be covered according to the Bright Futures periodicity schedule for those individual and group non-grandfathered plans. So where some of these services may have been bundled under your commercial plans previously, under this provision, some of these services will have to be paid according to the ACA. So we have evaluation and management, hearing and vision screens. Those are often bundled with commercial plans. The vaccine administration, any lab procedures that are done, the use of developmental and behavioral screening tools, health risk assessments. If you have a sick visit on the same day as a well, you can report that separately as well. And then any unrelated procedures to a preventive service. So oftentimes the child may have some procedure done in conjunction with a preventive service, and you think that you shouldn't report that, but you actually can. The next set of codes that we're going to look at are pretty much your bread and butter codes. So these are your new and established office visit codes. And I want you to pay particular attention to the time that's associated with these codes, because in the medical home, a lot of the visits that we see with our kids with chronic conditions, ADHD, behavioral health problems, emotional problems, obesity, oftentimes we can't meet some of the requirements for the E&M services with our history exam and medical decision making. But we can meet them with time when we're spending an extensive amount of time in these visits. So that's why I want to point out the significance of time, and we're going to talk a little bit more about that in the next couple of slides. So one of the things that you want to, these are the established patient visit codes, which you probably use most often in your office. One of the things I want to point out is that if you spend over 50% of these total times in counseling and coordination of care, then time will trump all other factors. So your history exam and medical decision making are trumped completely by time if you spend over 50% of that time in care coordination or counseling. You have to document that. You have to describe the services that you're providing care coordination or counseling for. So this is just an example talking about time is on your side. So it's probably a good idea to memorize, especially your established patient visit times, because those are the ones that you will most often use. So if the provider spends 25 minutes with a patient and over 50% of that time spent in counseling and coordination of care, you can bill a 99214. That's regardless of your history, your exam, and your medical decision making. It's all based on time. You have to document the time, and you also have to describe the counseling or the care coordination that you're providing. If you are on electronic medical record, you can build this time documentation into your template, so it's already there. So for instance, you can have a blurb that says, I spent X amount of time with the patient, over 50% was in counseling and coordination of care, and then you can have a place to free text what you did, what the counseling was about, or what the coordination of care had to do with. It doesn't have to be very, very detailed, but a brief description of what you did in that time. So some rules on time and the way that it works. So face-to-face time is patient or family face-to-face time in the office. In the hospital, you can count time as either face-to-face time with the patient or family, and you can also count any time that you spent on the unit or on the floor as when you're calculating your time to decide on what level of service to bill. So a unit of time is attained when the midpoint is passed. So for example, after 31 minutes have elapsed, then you can report up to an hour. The second hour is attained after 91 minutes. So when you have codes that have typical times assigned to them and your actual time falls between those two codes, you want to report your actual time closest to the E&M code. So on the next slide, you'll see an example. So 99214 is 25 minutes, and a 99215 is 40 minutes. So if you spend 35 minutes with the patient, and over 50% of that time spent counseling coordination of care, you can report the 99215 because the time falls closer to the typical time for 99215 than it does for 99214. This next chart just gives the typical times that are associated with your new and established E&M codes. So you have your typical time that's assigned, and then in the far right-hand column, you'll see the minimum time that's required to report that code. So for instance, on a 99214, once you hit the 21-minute mark, you can report 99214. Again, be sure that you're documenting your time and that over 50% was spent in counseling coordination of care. And I've said that a million times, but that has to be documented in the record in order to report based on time. And time makes a huge difference. So this chart shows you the increase in reimbursement going from level to level. So going from a level 99213 to a 214 is about $33 a visit. Calculate that over many patients and many months, and it makes a huge difference. Okay, so if you are spending additional time over and above what are assigned with our E&M codes, there are additional codes that you can report for prolonged care. So 99354 and 355 are used for prolonged services with direct face-to-face contact. So your contact has to be face-to-face with the patient. You can report these codes with any level E&M service, and the time doesn't have to be continuous. So if you're going in and out of the office, you can count what time you're face-to-face. Here's Dr. Kaufman performing some prolonged services. So for 99354, you would report for 30 to 74 minutes of prolonged care. And then after each additional 30 minutes would be the 99355. So here's an example. A 9-month-old previously healthy child and follow-up for failure to gain weight and increasing irritability with recurrent bouts of constipation. Because of family history of gluten intolerance, the physician wants to refer the child to a pediatric gastroenterologist. The parents are resistant to the referral. A total of 40 minutes is spent in providing the face-to-face E&M service, and then an additional 30 minutes was spent in counseling and coordination of care. So here, this is an extensive use of time in the office, and you would be reporting this based on time. So your office visit would be the 99215 for 40 minutes, and then you add on the prolonged service code of 99354. When you look at the reimbursement for this, you'll see that the 215 is about $140, and the 354 adds another $95. So this would be a time-based. You would be using time to report your 99215. If your history exam and medical decision making was only a 99213, you can report the 99213, and then you have, oh, by the way, we need to talk to you about XYZ for 30 minutes. So you can potentially bill a 99213 and the prolonged care. So it doesn't have to be time-based. This was just a time-based example. Okay, so the next set of codes that we're going to talk about are the non-face-to-face prolonged care codes. So these are used when physician is providing prolonged service that is not face-to-face, but it's beyond the usual non-face-to-face component of physician time. And what that means is that a lot of codes have a certain amount of pre and post work built into the code itself. And so this is for additional time that's not that usual pre or post time. So you report the non-face-to-face codes with another physician service, so any A&M at any level. You can also report these codes on a different date than you report the A&M, but it has to relate to either a previous A&M or a future A&M. So the question that you just asked, where the child was seen in the emergency room, they send the notes over, you review those notes before the child comes to see you, so you can count that time, that non-face-to-face time, if it's 30 minutes, in reviewing those notes, and then knowing that the patient will be seen in follow-up in your office, and it will relate to that next E&M service. You can bill it on the day that you, like the record review. If you receive the records from the ER, you can report it on that day. It doesn't have to be reported on the same calendar day. Okay, so you would use 99358 and 359 to report these services. Used once per day. The 358 is up to the first hour, and then 359 is for each additional 30 minutes. You do not use these codes to report time spent in medical team conferences, care plan oversight, or other non-face-to-face codes that have more specific codes assigned. So an example here would be like kind of what we just talked about, or the provider spends 40 minutes in his office reviewing extensive medical records for a patient that was admitted to the hospital. So then you would report the 99358. Reimbursement for this code is about $105, and then when you move to each additional 30 minutes, it would add another $50. And most of our MCO, our TennCare MCOs and commercial plans will reimburse for these codes. Okay, so this is just a chart that shows how many minutes you have to meet in order to use these codes. The codes in orange are for your outpatient, for your face-to-face codes, and the codes in blue are for your non-face-to-face. So less than 30 minutes is not separately reportable. Then you have a code for 30 to 74 minutes, and then if you hit the 75-minute mark, you can add on an additional code. The next set of codes that we're going to talk about are after-hour codes, and we really hope that we're going to see payer recognition for these codes, because these after-hours codes relay to the payer that your practice is accessible as a medical home. You're providing extended hours, weekends, evening holidays. This is a cost savings to the payer, because the child doesn't have to be seen in an urgent care or an ER. So we're hoping that we see increased participation in payer coverage for these services. The 99050 is typically covered by a lot of our TennCare MCOs and commercial plans, and this is for services that are provided in the office other than regularly scheduled office hours or days when your office would be normally closed. So for example, your posted office hours are Monday through Friday 8 to 5. You see a patient at 6 o'clock. you would report your E&M service, and then you could add on the 99050. Okay, that would be for these are when your hours are posted and you're seeing the child outside of posted hours. Then we have a 99051 that is not typically reimbursed by payers, and this is for services that are provided in the office during regularly scheduled weekend, evening, and holiday hours. So your posted hours are 8 to 12 on Saturday. You see a patient at 9 o'clock on Saturday, which is within your posted hours. You can report 99214 and 99051 for that service. There's a little technicality, I think, with the 99051 in that payers are kind of punished for having their hours posted. So this is a place where we really need to look at negotiating reimbursement with our payers. You know, hey, you're going to reimburse me if my hours are not posted and I see the child, but you're not going to reimburse me if I do post my hours and advertise that I'm here, I'm available, but you're not going to pay me. So that's kind of something that we need to work through with payers. So while the 50 and 51 do not have RVUs assigned to them, we do see the typical reimbursement for the 50 to be anywhere between $15 and $30. Again, you know, we do not see most payers reimburse for the 051. Okay, so now we're going to talk about care plan oversight. And care plan oversight is for non-face-to-face services by the physician who are supervising a complex patient who requires a multidisciplinary care or ongoing physician involvement. These services, again, are not face-to-face, and they reflect the complexity of time that's spent to supervise the care of the patient. Again, remember that this is for services that are provided by the physician in care plan oversight. So you can't count any other time by ancillary staff, nurses. This is just for physician time. So some of the activities under care plan oversight would be development or revision of a care plan, subsequent reports of a patient status, reviewing labs, diagnostic studies, communicating, including telephone calls. This is very important because our telephone codes that we have established in CPT, we know are often not reimbursed, if ever, by payers, and they have a lot of strict guidelines about how you report those. So this is one way that you can get your telephone calls paid for if you are including them as part of your care plan oversight. You have to have a care plan, remember. You can't just be on the phone 10 times a month to bill care plan oversight. The child has to have a care plan established, and you have to be supervising, revising that, being in communication with their family or other specialists that may be seeing that patient. Care plan oversight also incorporates team conferences, so those would not be separately reported. So the care plan oversight codes are based on the amount of time that a physician spends within a calendar month, so beginning with the first day of the month and ending at the end of the month. It's reported based on the patient's location. So they're either at home, they're under the care of a home health agency, they could be hospice, or they also could be in a nursing facility. So there are different code sets for each of those depending on the location of the child. Again, if you are seeing the child in your office in addition to providing care plan oversight for regular visits, you can also report E&M services for that child during the month. So the codes are 339 for 15 to 25 minutes and then 99340 for each additional 30 minutes. And plans are typically paying at the 30-minute threshold. We haven't seen a lot of movement on the 15 to 29 minutes. So the example here is a 4-year-old child with cerebral palsy at home. Provider documents time spent on telephone calls with mom regarding the team conferences, making revisions to the care plan. The child's referred to speech therapy, and there's discussion of the assessment in the plan. So a total of 43 minutes over the calendar month, and you would report 99340. Reimbursement for this code is about $105. So if you bill that for 12 months, you're looking at about $1,200 to your bottom line for care plan oversight. The next code, and I'm not going to go through all of the different locations, but this is for a child who is under the supervision of a home health agency. The same kind of rules apply. The codes are just different based on their location. This is just the same example, basically, but the child's under home health. You would report the different code, 99375, because they're under home health agency, and the fee's a little bit different, $101 versus $105. Okay. So now we're going to talk about two new codes that came out in 2013. And I think that many of our payers are recognizing the need for some type of code to accurately reflect all of the work that is being done outside of your typical evaluation and management or even your care plan oversight. These two new codes, what is unique about these code sets are that they include clinical staff time, where your care plan oversights did not include. It was only, like you can only report those for services that physicians perform. Now, a little caveat here, the complex chronic care coordination codes are not covered by Medicare. So we tend to, what Medicare tends to do, other payers tend to do. So I'm not sure about coverage for these codes at this point in time. However, in the 2014 final rule for the physician fee schedule, CMS has said that they will be developing two new G codes that will be separately paid in 2015. They're going to look a little bit different. Preliminary indications point to, number one, they will only be provided for 20 minutes during a calendar month, where our complex chronic care coordination codes can go up to an hour or more. The other thing that has been mentioned is that you would have to be on certified electronic medical record to build these codes, and they have even mentioned that you would have to have either a nurse practitioner or physician assistant employed in your office. So what those codes will look like and what the guidelines will be are yet to be determined, but we will see those in 2015. But right now we can talk about what our CPT book tells us for chronic care coordination codes, because that's all we have to go by right now. I think CMS agreed that there needed to be some type of reimbursement for this type of service, but they just didn't agree with the exact CPT codes, so they're going to come up with their own codes. But let's just look at what complex chronic care coordination services is. So this is patient-centered management and support services provided by physicians and other qualified healthcare professionals and clinical staff. So that's what's important about these new codes, is that you can include the clinical staff time that's spent in care coordination. So some of the services that would be provided under these codes would include, These are for services that are provided to a patient who is either at home, in a rest home, or assisted living facility. And it's the clinical staff implementing out the care plan as directed by the physician or other provider. They would be addressing the coordination of care across multiple disciplines and community service agencies, reporting individual provides or oversees the management or coordination of services is needed for all medical conditions, psychosocial conditions, and activities of daily living. These services include moderate or high complexity medical decision making within a calendar month. A plan of care should be documented and shared with the patient or caregiver. The face-to-face and non-face-to-face time spent by clinical staff in communicating either with the patient or family should be documented. If you are revising care plans, if you're changing medication, teaching self-management, all of those things are included in the services for care coordination. So there's three different codes. So the first code is 99487. And this is for the first hour of clinical staff time directed by a physician where no face-to-face visit occurs per calendar month. So this is just for your overall care coordination in the office for the first hour. The next code includes an hour of clinical staff time directed by the physician, but also includes one face-to-face visit with the patient during the month. And then you have an additional add-on code for each 30 minutes that would be separately reported in addition to these first two codes. If you have other E&M services during the month, you may report those separately in addition to. But remember, with the 99488, you have to have that one face-to-face visit as part of that code in order to report it. Services that would count towards clinical staff time under this code would be communication with the patient, family, guardian, other healthcare providers, home health agency, assessment, making sure they're adhering to their medication management or treatment regimen. If you're identifying community services or health resources, that would count as time spent. So those are just some examples. So an example for the 99487, a 6-year-old has spastic quadriplegia, gastrostomy, gastroesophageal reflux, and recurrent bouts of aspiration pneumonia with reactive airway disease, chronic seizure disorder, failure to thrive, and severe neurodevelopmental delay. So the child is receiving home, occupational, physical, and speech therapy services. A total of 40 minutes is spent in that care coordination. You would then report the 99487. The next example is for a face-to-face visit. So you have a 12-year-old who has severe atopic disease, recurrent asthma, led to multiple ED visits, hospital admissions, school days lost, and behavioral adjustment reactions. The child has one office visit during the month, and then 40 minutes was spent in care coordination for the month as well. The code would be reported would be 99488. In this case, the office visit is included in this 99488, were the child to come in another day during the calendar month, in addition to this scenario, you could report an additional E&M code, like with 99213-214. So when we look at reimbursement, I know she gave you figures, and by the way, all of the reimbursement figures that I'm giving you today are based on the 2013 Medicare fee schedule. We're not really supposed to talk about fees, but this is a way that we can talk about fees under one rate here. Okay, based on the 2013 rates, it should be around $80 for the 487, $180 for the 488, and $40 for 489. And these should coincide with primary care payment bump, because the primary care payment bump raised those certain codes to the Medicare fee rate. So these should really coincide. Okay, the next set of codes that we're going to talk about are transitional care management services, and these are services that are currently covered by Medicare. I'm not sure what other plans are doing at this point, but I would think that they would begin to follow suit. So TCM, short for Transitional Care Management, services are provided for new or established patients whose medical or psychosocial problems require moderate or high complexity medical decision making. Again, with both of these code sets, the medical decision making has to be moderate to high, where your care plan oversight codes did not specify what complexity of medical decision making you needed. So during transitions and care from an inpatient setting back into the hospital, those are how, that's the purpose of these codes, is to report when the patient transitions from the hospital back into the primary care setting. So both transitional care management codes will include one face-to-face visit. It has specified time frames. There's non-face-to-face time that's included in these codes and must be performed by a physician, and this also can include clinical staff time. If you have additional E&M services beyond the first service that's included, you can report that in addition to. So here are the requirements for the transitional care management codes. The patient has to be contacted within 2 business days of discharge. This can be via text, email, phone call. It can be the provider. It can be someone in your office that makes that phone call, but they have to be contacted within 2 days. A face-to-face visit has to occur within 7 to 14 days after discharge, and then also medication reconciliation has to be performed. So those are the 3 requirements that you have to meet in order to report these codes. So the 99495, basically the difference in the 495 and the 496, 495 is moderate complexity, and the child has to be seen within 14 days. On the 496, the medical decision-making is high, and the child has to be seen within 7 days. So if you're not at, if you have moderate complexity, but the child's seen in 7 days, that doesn't matter, okay? It's the high complexity, and then the child has to be seen within 7 days. So if you have moderate complexity, no matter when the child comes back into the office, you're going to bill the 99495. Just remember, these are pretty complex kids, so it would be, I guess, clinical judgment as to whether you thought that they were highly or moderately to highly complex. The services provided on the clinical staff time portion of these codes is very similar to your complex chronic care codes, so communication with family members, home health agencies, referrals to specialists, reviewing tests, teaching self-management skills, that type of thing. Non-face-to-face services provided by the physician or other qualified health care professional would include obtaining and reviewing discharge information, reviewing diagnostic tests, interaction with other professionals, education to the patient and family, etc. So the example for the TCM codes, we have a 6-year-old who's neurologically impaired, developmentally delayed with chronic seizure disorder, discharged from the hospital after admission for breakthroughs. So 2 days after the discharge, physician talks to the mom. The clinic staff assesses their adherence to the treatment plan and educates the parents on management of the child. The child is seen back in the office in 10 days after discharge, and the medical decision-making is moderate. Therefore, you would report the 99495. Next example is a 6-month born at 25 weeks gestation with chronic lung disease on oxygen, diuretics, bronchodilators, etc., discharged from the hospital after respiratory failure. The physician talks with the mom on the day of discharge. Clinical staff makes sure that there's adherence to the treatment plan, and then the child is seen in follow-up within 5 days. In this case, the medical decision-making is high, so you would report the 99496. Reimbursement for these services is quite hefty. 99495 is about $160, and then 99496 is about $225. Okay, they can, except your discharge day cannot count as your face-to-face visit, your first face-to-face visit. So when they're discharged, the first time they come into the office is their first face-to-face visit that would be included in these codes. You can't count that discharge day. If you're providing all of the requirements that you have to provide to report these services, number one. So you have to have your clinical staff or you or another provider who is providing care coordination along with that first visit transitioning back in the office. So you have a discharge charge that you can report. Then you have the first visit with the patient with all of the care coordination provided by your clinical staff. That's all included. So there's not a separate visit reported unless the child comes back. They can be seen within 7 days and then come back again in 2 weeks, and you can report another service. Does that answer your question? Are you still confused? We can talk further if we need to. I'm being flagged for time. So real quick, we'll talk about a couple of developmental behavioral screening codes. So AAP recommends developmental and behavioral screenings at certain intervals or at other times if the need is there. So developmental screening at 9, 18, and 30 months, autism screening at 18 and 24 months, a new recommendation for depression screening, 11 to 21, and then alcohol and drug use assessment, 11 to 21 years. So the coding for most of these screens is 96110, which would be reported for your MCHAT, PEDS, ages and stages, etc. We normally use this in conjunction with an EPSDT, but it can also be billed with a sick visit. This is just information about the usage of modifiers, which varies by payer. The other code I want to talk about is 99420. This code is now recommended to be used for the Edinburgh Postnatal Depression Scale and also for the CRAFT, which is the Alcohol and Drug Use Assessment Tool. So the next slide pretty much just tells you the same thing. AAP now recommends that you use 99420 for the Edinburgh and then also for the CRAFT. If you have a CRAFT that is positive and you also perform a brief intervention with the child, you would report 99408 instead of the health risk assessment code. When you're reporting these codes, you want to be sure that you're including the screening tool, that there's an interpretation or score, and that there is physician signature. And if reported with an evaluation and management service, it requires modifier 25. The fee or reimbursement for both of these codes is about $10. And that's all I have. One thing I want to mention really quickly, we talked about the ACA preventive services provision. AAP has put out a really nice toolkit for preventive services, and it's broken down into coding documents going from prenatal visit to 21, and it tells you what services should be covered for that visit, gives you the CPT code, the diagnosis code for each visit from prenatal all the way to 21, and those are available. You can reach that link on our website. The new periodicity schedule is also out there as well.